tubular and interstitial renal diseases. As you do know, the functional unit of the kidney is the nephron. It consists of the glomerulus, the renal tubules and interstitium, and the renal vessels. This lecture is concerned with the common tubular and interstitial renal diseases. Although the tubules and the interstitium are distinct functional entities, they are interrelated. Injury involving one of them results in damage to the other. The items that will be discussed are tubulointerstitial nephritis, analgesic nephropathy, reflux nephropathy, and pyelonephritis. We shall start with interstitial nephritis. Interstitial nephritis is a pathological term denoting an inflammation involving the interstitium and renal tubules. According to the nature of this inflammation, interstitial nephritis is classified into an acute and chronic interstitial nephritis. Acute differs from chronic interstitial nephritis regarding its etiology, clinical presentation, investigations, and management. Acute interstitial nephritis. Drugs and toxins are the most frequent cause for the development of an acute interstitial nephritis. They are responsible for about 70% of these cases. The second most common cause is infection related, which occurs in almost 15% of the cases. The remaining 15% of acute interstitial nephritis is idiopathic, immune-mediated, and tubulointerstitial nephritis with uveitis. The most common cause for the development of acute interstitial nephritis is exposure to drugs. The antibiotic group of drugs is the most common cause, among which methicillin is the most frequent. Other antibiotics that can induce acute interstitial nephritis include ampicillin, rifampicin, and sulfonamides. Other groups of drugs that can induce acute interstitial nephritis include analgesics, non-steroidal anti-inflammatory drugs, H2 blockers, and diuretics. As well, toxins and their exposure can induce an acute interstitial nephritis. These toxins that can induce an acute interstitial nephritis include organic solvents and the fungal toxin ochratoxin. A lot of organisms can induce acute interstitial nephritis, including the bacteria such as the streptococci, the diphtheria, the brucella, the legionella, the mycobacterium tuberculosis, and mycoplasma. Viruses such as the rubella virus, the cytomegalovirus, the Epstein virus, and the hantavirus. Protozoa such as Toxoplasma gonadii can induce an acute interstitial nephritis, and spirochetes such as in leptospirosis. Acute interstitial nephritis results from the direct invasion of the interstitium by the organism, or it might occur with systemic infection. In such a situation, the lesion is due to the bacterial toxin or an immunologic process that is triggered by the organism. The underlying mechanism is an immunologic reaction in response to the infection, toxins, or drugs. It's mainly a cell-mediated immune response, and to a much lesser extent a humoral reaction. Less commonly, acute interstitial nephritis might be idiopathic or immune-mediated, such as in Sjogren's syndrome, in systemic lupus erythematosus, and in transplant rejection. What happens in the kidney in the acute interstitial nephritis? Macroscopically, since it is an acute inflammation, the kidney size is still normal or even increased due to the presence of the edema fluid microscopically, and that is what's seen under the microscope in a renal biopsy. The most characteristic is that the lesion is restricted to the interstitium and the renal tubules, while the glomeruli and the renal blood vessels are intact. The interstitium shows edema and a cellular infiltrate, since it is a cell-mediated immune response. The predominant cells are the lymphocytes, and the most characteristic is the presence of plasma cells. When the cause is a drug, in addition to the lymphocytes and the plasma cells, there are polymorphs and eosinophils. The tubules are normal or they show tubular necrosis. The clinical picture in a patient who develops an acute interstitial nephritis is quite variable. It starts mainly, in most instances, with the exposure to the drug or an infection related. The patient might develop a severe hypersensitivity syndrome with its characteristic triad of fever, skin rash, and eosinophilia, in addition to an acute renal failure. The patient might be asymptomatic, but the investigations show a slight increase which is progressive in the serum creatinine. The condition might be less severe and the patient is even asymptomatic without a rise in the serum creatinine, but with abnormal urinary sediment. Worth to mention is that in the drug-induced acute interstitial nephritis, the interval between the exposure to the injurious agent and the onset of the symptoms varies from few hours to several months. The absence of the characteristic cell, the eosinophils, in the blood in the form of eosinophilia and in the urine in the form of eosinophiluria does not exclude an acute interstitial nephritis. When the patient develops an acute interstitial nephritis, it has to be differentiated from other causes of an acute kidney injury, including acute tubular necrosis, a rapidly progressive glomerulonephritis, and an atheroembolic renal artery disease. The diagnosis of acute interstitial nephritis starts from the history, with exposure to a drug or infection, the clinical presentation of an hypersensitivity syndrome with an acute kidney injury, and finally the laboratory investigations. In the complete blood count, there is an eosinophilia. The urine shows an eosinophiluria, and this is the most characteristic abnormality. Other urinary abnormalities include a tubular proteinuria, which is less than 1 gram per day with low molecular weight proteins, leukocyturia, and microscopic hematuria. The definitive diagnosis is through a renal biopsy, which shows an intact glomeruli and blood vessels, and the whole lesion is restricted to the interstitium and renal tubule. The most important point in the treatment of an acute interstitial nephritis is to find out the cause. So if it is due to an exposure to a drug, this drug has to be discontinued. If it is due to an infection, the appropriate antimicrobial should be used. In most instances, supportive treatment of an acute kidney injury is sufficient. Sometimes steroids are given to shorten the course and to prevent permanent renal damage. Chronic interstitial nephritis. The most common causes for a chronic inflammation in the tubules and the interstitium of the kidney is an analgesic nephropathy, the reflux nephropathy, gouty nephropathy, obstructive nephropathy, and chronic pyelonephritis. Less commonly, chronic interstitial nephritis might occur in the chronic phase after an acute interstitial nephritis, or due to exposure to drugs containing lithium, such as the antipsychotic drugs, or exposure to heavy metals, including the lead, the mercury, and the cadmium, or due to radiation nephritis, which occurs as a complication of irradiation when the kidney comes into the field of irradiation without adequate protection. 6 to 12 months after the exposure, the patient develops a severe hypertension and a progressive chronic kidney disease. Balkan endemic nephropathy is a form of chronic interstitial nephritis which is found in Romania, Bulgaria, and Yugoslavia. It's mostly due to the exposure to the ochratoxin or heavy metals, and it is characterized by a chronic interstitial nephritis and sometimes a transitional cell carcinoma. Other causes of a chronic interstitial nephritis include the sickle cell disease, the Sjogren's syndrome, and neoplasia such as multiple myeloma and leukemia. Early in chronic interstitial nephritis, the clinical presentation is that of the etiologic cause. But as the disease progresses, the patient develops the different stages of the chronic kidney disease, and finally he develops an end-stage renal disease. While the patient is in the early stages of the chronic kidney disease, since it is a disease of the tubules and the interstitium, which is a salt-losing nephropathy, the patient is complaining of polyuria, nocturia. There is no edema, no hypertension, but there is a severe metabolic acidosis, an advanced bone disease, a severe anemia, which is sometimes associated with a tubular proteinuria and a microscopic hematuria. The main line of treatment of chronic interstitial nephritis, if it is early, is the treatment of the etiologic cause. But once the patient progresses and he develops chronic kidney disease, the treatment is that of a conservative management of a chronic kidney disease. And once the patient reaches the 5th stage of the chronic kidney disease, which is the end-stage renal disease, the only solution is a renal replacement therapy in the form of dialysis or renal transplantation. Analgesic nephropathy. This is a common cause for chronic interstitial nephritis. It is a part of the analgesic syndrome. It occurs in individuals who abuse the non-steroidal anti-inflammatory drugs for a long period of time. Those patients who abuse the non-steroidal anti-inflammatory drugs for a long period of time develop what is known as analgesic syndrome. This is a multi-organ and a multi-system manifestation. For example, the gastrointestinal tract is affected in the form of dyspepsia, gastric ulcer, and relapsing pancreatitis. Hematologically, there is anemia and a palpable spleen. Cardiovascular manifestations include hypertension, premature atherosclerosis, coronary artery disease, cerebrovascular strokes, and peripheral vascular disease. Neuropsychiatric manifestations for those who abuse the non-steroidal anti-inflammatory drugs for a long period of time include headache and personality changes. Pregnancy and gonadal manifestations include subfertility and toxemia of pregnancy. As well, they might develop premature aging and hyperpigmentation of the skin. The peak age of incidence for the development of analgesic nephropathy is 40 to 60 years. Females develop analgesic nephropathy 7 times as much as males. Despite that, the analgesic consumption ratio is only 2 to 1. This means that females are predisposed to the development of analgesic nephropathy when they abuse the non-steroidal anti-inflammatory drugs. Other predisposing factors are the analgesic mixture, which is more serious than a single drug exposure. The cumulative dose, at least 2 kilograms of aspirin or phenacetin or an analgesic mixture, is required for the development of an analgesic nephropathy. The duration of non-steroidal abuse, of course, the longer the duration, the more serious the condition and the more advanced is the renal involvement. Hydration status is an important point. If there is no alternative for the abuse of the non-steroidal, at least you have to instruct the patient to drink a lot, and this reduces the concentration of metabolites in the kidney. Climatic factors. For example, in Egypt, as the weather is relatively hot, it's more serious to abuse the non-steroidal anti-inflammatory drugs than in cold areas. There is a genetic predisposition for the development of analgesic nephropathy, which is related to the human leukocyte antigen A3 and B12. Those who abuse the non-steroidal anti-inflammatory drugs develop the following in their kidneys: a renal papillary necrosis, which is the primary feature of analgesic nephropathy. It is due to medullary cytotoxicity and ischemic infarcts. Vascular sclerosis, which affects the small arterioles and venules in the renal medulla and in the submucosa of the renal pelvis and urinary tract. A chronic interstitial nephritis, and finally a transitional cell carcinoma of the urothelium. The ratio of urinary bladder to the renal pelvis tumors in analgesic nephropathy is 1 to 11. In the normal patients, it's much more common to develop a transitional cell carcinoma in the urinary bladder than in the renal pelvis, with a ratio of 15 to 1. These are the changes that occur in the capillaries and in the small arterioles and venules in the renal medulla and in the submucosa of the renal pelvis and the urinary tract. There is thickening of the wall with narrowing of the lumen. A more advanced stage with further thickening of the wall and narrowing of the lumen. And in very advanced stages, there is almost a complete obliteration of the lumen. These are the radiological signs of analgesic nephropathy. There is wavy outline of the kidney. 1. There is a normal calyx. Here in 3, there is partial papillary necrosis with a central cavity and a fistula. In 4, there is complete papillary necrosis with a ring shadow. There is the development of a transitional cell carcinoma, and as I mentioned, in the analgesic nephropathy, it occurs in the renal pelvis, more common than in the urinary bladder. And when there is necrosis of the papilla, these sequestered papilla occur in the pelviureteric junction, resulting in ureteric occlusion. The prophylactic treatment for the analgesic nephropathy is that you have to totally avoid the non-steroidal anti-inflammatory drugs, and paracetamol is a reasonable alternative. You have to instruct the patient to maintain a high fluid intake exceeding 2 liters per day. You have to treat the complications that might develop, including the hypertension, the metabolic acidosis, and the urinary tract infection. You have to keep an eye on this patient for the long-term complications or the late complications that might develop, including the malignancy, the urinary tract infection, the development of stones, and renal artery stenosis. Reflux nephropathy. Vesicureteric reflux is the backflow of urine from the urinary bladder to the ureter. The reflux nephropathy is the chronic interstitial nephritis that is characterized by coarse renal scars that develop as a complication of vesicureteric reflux. Renal scars develop during infancy or early childhood, and they become fully developed by adolescence. Three factors are interacting. These are the vesicureteric reflux, the intrarenal reflux, and the recurrent urinary tract infection. Reflux nephropathy is a disease of young school girls. It develops in females 5 times more common than males. In schoolgirls, bacteriuria is detected in 1 to 2% of them. Vesicureteric reflux is the cause in 20 to 30% of them, which usually disappears around the age of puberty. Reflux nephropathy occurs in 0.3 to 0.5% of these young school girls. What about the clinical features of vesicureteric reflux? Urinary tract infection. This is the most common presentation, and it is usually recurrent. In neonates, there is failure to thrive and recurrent fever. In children, the full-blown picture of a urinary tract infection, as it will be mentioned later. Hypertension. To know the magnitude of the problem, 60% of the hypertension in children is due to a reflux nephropathy. Chronic kidney disease. Almost 10% of patients who are on dialysis at the age of 30 is due to reflux nephropathy. Other clinical features include a positive family history, a childhood enuresis, loin pains, the development of renal stones, and the presence of other congenital anomalies such as a duplex ureter and a posterior urethral valve. The diagnosis of reflux nephropathy is achieved via the intravenous urography, which shows a disparity in the kidney size and shape with cortical scarring and calyceal clubbing. Another method for the diagnosis is the isotopic renogram, the DEMSA scan, which shows scarring or inflammation. Other methods include a micturating cystourethropy and cystoscopy. Renal biopsy is only indicated if the intravenous urography and the DEMSA scan show no scarring. This is the intravenous urography, which shows the irregularities of the outline of the kidney and calyceal clubbing with cortical scarring. Treatment of reflux nephropathy includes the control of infection, and this is achieved via the prophylactic antibiotics in the form of Septrin, 1 tablet at bedtime till puberty or till the reflux disappears. If a superadded infection occurs, this has to be aggressively controlled. If the patient develops a hypertension, this should be controlled adequately. Anti-reflux surgery is controversial as it does not prevent the progression of the renal disease. The methods include the ureteric reimplantation into the urinary bladder or the cystoscopic injection of a material such as collagen around the ureteric orifice to make it narrower. Pyelonephritis. Pyelonephritis is the microbial infection involving the renal pelvis and the renal parenchyma. It is usually associated with constitutional symptoms in the form of fever, rigors, chills, myalgias, and arthralgias due to the parenchymal involvement. Pyelitis is an infection that is mainly affecting the renal pelvis. It is usually not associated with constitutional symptoms. The non-specific defense mechanisms of urinary tract against infection include the flushing effect of voiding, the urinary bladder glycocalyx, the glycosaminoglycan, the Tam-Horsfall glycoprotein, mucosal phagocytosis, and the endotoxin-induced shedding of the bladder epithelial cells. The specific immunological mechanisms of the urinary tract include in the lower urinary tract the secretory IgA, and in the upper urinary tract the secretory IgA and the circulating IgM and IgG. Pyelonephritis is classified according to the nature of the infection into an acute pyelonephritis and a chronic pyelonephritis. Acute pyelonephritis. The predisposing factors for the development of an acute pyelonephritis include the anatomic abnormalities of the urinary tract, such as the vesicureteric reflux, the strictures, and anatomic abnormalities of the kidney, such as the horseshoe kidney, the presence of renal stones, a urinary tract obstruction, such as the benign prostatic hyperplasia, the presence of a systemic disease that predisposes to infection, such as diabetes mellitus, the abuse of the non-steroidal, as previously mentioned, resulting in analgesic nephropathy, and the instrumentation of the urinary tract, such as a urinary catheter, and the presence of a neurogenic bladder with the presence of a residual urine and stasis. The precipitating factors for the development of an acute pyelonephritis are the presence of a short urethra, such as in females, the trauma to the urethra, and the stasis of urine, which occurs in pregnancy. And 5% of the pregnant women have got a persistent bacilluria, of whom 30 to 40% develop an acute pyelonephritis. Acute pyelonephritis is most often caused by bacteria, the most common of which is the Escherichia coli. But when the infection is due to instrumentation of the urinary tract, or it is associated with an anatomic abnormality of the urinary tract, other organisms might be found, such as the Proteus, the Klebsiella, the Pseudomonas, the Staph saprophyticus, or Epidermidis. Regarding the route of infection of the urinary tract, by far the most common route is the ascending transurethral route. Other routes include the bloodstream, the lymphatics, or direct extension through a vesicocolic fistula, which communicates the GI and the urinary tract. This is the most common route of infection of the urinary tract. The gut flora undergo periurethral colonization, then a transurethral ascent, and finally establishment and multiplication in the urinary bladder. A point of importance in the management of an acute infection of the kidney, an acute pyelonephritis, is to differentiate a urinary tract infection, whether it is complicated or uncomplicated. This is achieved through an excretory urography. If there is an abnormality in the excretory urography in the form of the presence of stones, an obstruction, or a vesicoureteric reflux, this is considered a complicated urinary tract infection. And even if there is no abnormality in the excretory urography, but there is a systemic disease that predisposes to infection, such as diabetes mellitus, sickle cell disease or trait, the analgesic abuse, all these in the presence of an abnormality of the urinary tract or a systemic disease predisposing to infection, this is considered a complicated urinary tract infection. And here there is a high risk of kidney damage and septicemia. But if there is neither an abnormality of the urinary tract as shown by the excretory urography, and there is no systemic disease predisposing to infection, this is considered an uncomplicated urinary tract infection, and there is a very low risk of kidney damage and septicemia. What happens in the kidney in an acute pyelonephritis? Macroscopically, since it is an acute infection, the kidney is normal in size or even enlarged due to the presence of edema. The pelvic mucosa shows a congestion, and in severe cases there are scattered small abscesses. Microscopically, as shown in a renal biopsy, the glomeruli and the blood vessels are normal. The renal interstitium shows edema and infiltration by acute inflammatory cells, the polymorphonuclear leukocytes. The tubules show pus cells and leukocyte casts. The symptoms in a case of an acute pyelonephritis differs according to the age. So in adults, there are constitutional symptoms in the form of a fever, malaise, body aches, muscles and joints. Locally, there is more frequent emptying of the urinary bladder. There is discomfort during micturition, hematuria, and the patient might develop renal colics due to the passage of the papilla. In children, there is abdominal pains and screaming on micturition. The signs include tenderness in the loin and suprapubic, and the urine is turbid and smells fishy. For the diagnosis of acute pyelonephritis, urine examination is sufficient. However, it is not sufficient for the evaluation of the case. You have to estimate the renal function, as it might modify your choice for the antibiotic regarding the type or the dose. You have to make a renal ultrasound so as to detect the predisposing factors such as a stone or a back pressure. In the urine, you have to make a microscopic examination which will show pus cells and sometimes bacteria. The dipstick test is used to detect nitrites, as the gram-negative bacteria reduce the nitrates which are normally found in the urine into nitrites, and the presence of leukocyte esterase denotes the presence of pyuria. So a positivity of both nitrite and leukocyte esterase denotes that there is an acute infection that is caused by gram-negative bacteria. To obtain a urine culture, a clean catch midstream urine specimen or suprapubic aspiration in children is indicated. To diagnose a urinary tract infection, the bacterial count should exceed 10 to the power 5 organisms per milliliter of urine. The low count bacteriuria is the presence of more than 100 organisms per milliliter of urine in the presence of pyuria. The term sterile pyuria denotes that on microscopic examination of the urine, pus cells are found, but when a urine culture is done, it yields no organisms, and this is repeatedly found. The causes of sterile pyuria include the culture is done while the patient is on antibiotics, the presence of a urinary tuberculosis, the presence of renal stones, a urethritis that is caused by organisms other than bacteria such as viruses, fungi or chlamydia, analgesic nephropathy, and the non-specific inflammation of the urinary. The treatment of an acute pyelonephritis is either prophylactic or an antimicrobial treatment. The prophylactic treatment of an acute pyelonephritis includes instructing the patient to drink sufficient fluids to maintain a urinary output exceeding 2 liters per day, to void every 2 to 3 hours with double micturition if there is a vesicoureteric reflux, voiding at bedtime, avoiding bubble baths and chemical additives to the bath water, and avoiding constipation which may impair urinary bladder emptying. The antimicrobial treatment differs according to the situation. So if it is the first or an uncomplicated infection, empirical antibiotics could be used in the form of ampicillin, amoxicillin, or Septrin for 7 to 10 days. But if it is a resistant, a recurrent, or a complicated infection, antibiotics should be given according to a recent culture and sensitivity. And if there is a high fever, loin pain, and tenderness, you should use an intravenous broad-spectrum antibiotic such as cefuroxime, gentamicin, or ciprofloxacin till the symptoms improve. Then you have to continue for another 7 days with an oral antibiotic. A relapse of a urinary tract infection is a symptomatic recurrent urinary tract infection with the same organism following therapy. Reinfection is a symptomatic recurrent urinary tract infection with a different organism following therapy. This might occur due to the wrong choice of the antibiotic from the very beginning, the use of an inadequate dose or duration of treatment, the presence of a missed anatomic abnormality, or a female. The treatment of such a situation is a good vulval hygiene, a long antibiotic suppressive therapy, and to correct the underlying anatomic abnormality. In those patients who are hospitalized with an indwelling catheter, colonization of urinary pathogens in and around the catheter is common. As long as the catheter is in situ, the antibiotic treatment is not effective. The indication for antibiotic treatment is that when the patient becomes symptomatic or there is evidence of infection, and in all instances you have to replace the catheter. Candida infection of the urinary tract is frequent with prolonged urinary bladder catheterization. Treatment is indicated if the patient is immune compromised or there is evidence of invasive infection. The treatment is the replacement of the catheter and the installation of intravesical amphotericin. In a pregnant woman, urine should be cultured, as 2 to 6% of them have asymptomatic bacteriuria. Failure to treat this bacteriuria may lead to severe symptomatic acute pyelonephritis later in pregnancy and premature labor. In a pregnant woman with asymptomatic bacteriuria and a previous kidney disease, this will predispose to preeclamptic toxemia, the anemia of pregnancy, and small or premature babies. Not all antimicrobials are safe during pregnancy. Those that should be avoided include the tetracycline, the trimethoprim, the sulfonamides, and the commonly used quinolones. Safe antibiotics to be used during pregnancy include amoxicillin, ampicillin, cephalosporins, and nitrofurantoin. Thank you.